We are back here on Healthy Living with our friend, Dr. Kirk Johnson. Thank you so much for joining us.
Good to see you again.
You know, the last time I think we talked, it was the beginning of COVID, so this is a treat to talk to us.
Yeah, amazing. Yeah.
Well, and I tell you what, I think during COVID, at least for me, I found myself actually exercising more, using my body more, moving more. And we thought it might be interesting today to chat a little bit about the impact, good or bad, that may have on us when we do move. And we're going to talk a little bit about knees today. And I have to tell you, for all of you listening, you're not going to want to miss this because it's absolutely fascinating. And I get kind of the inside scoop and get to hear a little bit before you do. And just the new technologies and what you're doing now are really pretty impressive. So chat with us about, first of all, when and why and at what point might I need a new knee?
So first of all, I'll say you were one of the few during COVID that got more active. I'm dealing with
really?
The COVID-20 or the COVID-30.
Oh.
I mean, people who really
ballooned up.
Yeah, and
happens,
it's very common. So there were a lot of unhealthy behaviors during COVID that affected what I do, because if somebody comes in and needs a knee replacement or hip replacement, I'm really very, very strict about not doing something like that if they need to lose weight. So I have a BMI cutoff of 30.
Okay.
And not that the numbers is critical. If you look at a BMI chart, 30 says you're overweight or even obese, when in fact that's a bad label.
Right.
But to be above 30, you're running an increased risk of blood clot or infection. So if you come to me and you've put on the COVID 30 or 20, yeah, I may say you need a knee replacement, but you're going to first have to get yourself to a better place.
Oh, I did not realize that actual weight had well, it does make sense. Yeah. It's a joint.
It changes the metabolism of your body, the way you deal with immune reaction. If you're obese, you're not as capable of coping, immune-wise to.
That makes perfect sense. Old school, or you've got some really fun things. So talk to us about when we would actually need a new knee.
Okay, so knee replacement, I'm sure people that are listening have neighbors or themselves have had knee replacement. So it's a wonderful technology developed when I started as a resident in the late 70s and has evolved over the past 40 plus years to now, where we're now still using newer technology. So if you have osteoarthritis, which is genetically
linked.
Can't pick your parents. So if genetics are there and you have loss of cartilage, once you reach bone on bone, you need to consider a knee replacement.
What are you going to be feeling? What are people feeling? Are they feeling dull ache? Are they feeling pain? Is it upon movement? Is it shifting?
So it's all of the above. Some people don't ever use the P word, never say pain.
Okay.
But they say stiffness, they say tightness.
Got it.
But when it becomes critical for those people that don't really complain of pain, it's when they lack confidence in their knee. So their knee, they don't trust their knee. They step off a curb and they feel like their knee's going to give way. So that's one circumstance where we have to consider doing something. People start to cut back on what they've been doing for an active lifestyle. Not a good idea.
Okay.
People start having sleep disturbance. Not a good idea.
Oh, interesting.
So those are the triggers where you really want to think about getting yourself fixed.
So we come to you initially, and you kind of take a look at it and make an assessment. My assumption is that surgery is probably the last thing that you do after you consider, like you said, BMIs and lifestyle things. When it's time for me to have surgery, what does that look like? Let's talk about some of the newer technologies that you personally are doing.
Okay, so you're absolutely right. You go through a series of conservative steps. Even if I see somebody for the first time and I know they have stage 4, which means it's bone on bone, there's no stage 5, they're at stage 4, I know they're gonna need a knee replacement. I'm probably, unless they come in saying, I'm here to have my knee replaced.
Correct.
I've done the research.
This is it.
I've looked at you, Johnson, so I'm here because whatever process they went through. Then we go ahead and we talk about that. But if somebody's coming for the first time, don't know the condition of their knee, I'm not likely to tell them you need to get your knee replaced. I'm going to try to work through a more conservative approach so it becomes their idea, if you know what I mean.
I do, it
to
makes
go
sense.
through a knee replacement. So, but if the decision is made, then we talk about the general process, the time it takes. Do you have to stay overnight? The answer is no. In the hospital. Yeah. So most of our knees are now outpatient.
All right, so let's talk about the general process.
Right.
We've decided I need a new knee.
Right.
Tell me a little bit exactly what you would be doing.
Right.
So let's see what my old knee looks like.
So a normal knee has nice smooth white cartilage, smooth. A worn knee, that cartilage is no longer white and smooth, it's eroded, it's pitted, it's irregular, and that's why the knee feels lousy, because it's not. The analogy I use is walking on a newly paved road versus a cobblestone street.
Oh.
Like the look of the cobblestone street, but it's not a great place to walk. Uneven, unpredictable, you gotta watch what you're doing. So that's sort of the picture of a cobblestone
That's
street.
the best analogy I've heard. That gives me a real visual of what my knee is experiencing inside. No wonder I'm unsteady. I'm walking on cobblestones.
So people think a knee replacement. I'm going to cut here, I'm going to cut here, I'm going to take the knee out, put a new knee in. A knee replacement is actually, think of it as a retread. So if you have a tire and you retread a tire, you still have your original wheel, your original tire, we're putting a new tread on. So a replacement of a knee is actually a retread. So this is the resurfacing of a knee. So we make cuts in the bone that are identical to the back side of the replacement, which is then placed over the end of the femur. So we put a new surface on. And for the last 35 years, we put that implant on with an acrylic cement that holds it in place. And still, 75% of the knees in the world are being done with cement, with bone cement.
However,
same is true on the downside. We put this in and cement it in place. What's going to fail in your bathroom, and another analogy, is it going to be the tile or is it going to be the grout? The grout is always the problem. So the same is true with cemented implants. If there's going to be failure over time, it's going to be loosening of the cement from the bone or the cement from the metal.
Which makes perfect sense to me, using that analogy.
So over the past 15 years, we've been using uncemented technology for hips. So this would be a hip replacement where there's a textured metal. The bone, once it's in place in the femur, the bone grows into the metal. And and this metal becomes part of the bone. Same true for the socket. Textured metal that is machined in a way that bone thinks that is bone, so it attaches
bone
itself.
To bone, got it.
So knees have been lagging behind in ingrowth technology for a lot of mechanical reasons, but we've finally arrived at the uncemented implant of the knee, which I've been now using for the past 6 years. We're approaching 1,000 patients.
Are you really? Oh my gosh.
So instead of using cement, we have this is called a triathlon knee. It's the name of the model of the knee, Triathlon. So when I give patients their operative note when they come back for 1 month, and I say, you need to know the name of the company, the model, which is Triathlon, and that it's uncemented. So anywhere in the world you could mention those 3 words and people would know exactly what you have. So what's new now compared to when I started in the late 70s?
Oh my gosh, I can't even imagine.
So it was a 4-hour operation. We did 1 a day, and it was a big deal. And it's still a big deal, but it was huge back then. So now most of our implants are in place in between 22 and 28 minutes. The balance of the hour is spent closing the wound. I spend a little extra time on my skin closures, so I use skin glue.
People ask us all the time, and I get it all the time too as a psychologist, are you retiring because I'm over 65? And the answer is I do think I'm getting better in many ways. How about you?
No question. So I hear every day, literally every other patient visit, I hear you're retiring. And the answer is yes, someday I am in fact going to retire. I have no plans because I've reached that point where what I'm doing is easier, more efficient, joyful, and decision making is a pleasure. So I'm old school. I like seeing my patients before, during, and after. I don't farm that out to PAs and nurse practitioners, which is not the economic good way, but it's the way I like to do things. So the bottom line is you're stuck with me for...
I love that. As always, it's super fun. And again, thank you for joining us. Stay with us. More to come on Healthy Living.